All right, welcome everyone to our academic hour. Today we will be having two journal clubs, first with Dr. Dixon, followed by Dr. Hallion. We'll have two separate Q&As for each of the presenters immediately following their journal club presentation. All right, thank you. Go ahead.
Hey everyone, my name's Evan Dixon. I'm a second year resident here at this program. The journal I chose today, or the article I chose today, was Long-Term Course of Remission and Recovery in Psychotic Disorders. I chose this because I felt like I had a fair amount of anecdotal evidence about the long-term course, but I had not visualized and seen a lot of like academic data on this. So I thought it was an interesting topic to explore. So our objectives today are listed here. I just want to review some terminology, evaluate some methodology, and then we can talk about improving understanding of trends and prognosis of symptomology in various forms of psychosis. And then later we can discuss implementable strategies and improving outcomes and reflect on the differences between our personal knowledge and observed outcomes in the study. So some definitions that I want to get out of the way because they're pertinent to the study, and I'll reference them later on. Psychosis, of course, is an amalgamation of psychological symptoms resulting in a loss of contact with reality. That's kind of broad, right? I'll go into a little more detail on the next slide about further defining it, especially for the purposes of the study. For this study, we use remission to mean presence of only mild symptoms. Recovery means mild to moderate symptoms and good psychosocial functioning. And then we'll talk about these trends. Stable just means that they're in remission or recovery across all time points. Early refers to having remission or recovery early in the time course. And then intermittent just doesn't fall into either of the other two categories. And then we discuss non-affective or non-affective psychotic disorders, which will be referred to throughout the study as SDD or schizophrenia spectrum disorders. And that includes schizophrenia, schizoaffective, and schizophreniform. And then affective psychotic disorders or other psychotic disorders, which are bipolar with psychosis, major depression with psychosis, and drug-induced psychotic disorders. To further define, earlier versions of DSM define psychosis as like gross impairment of reality testing, loss of ego boundaries. DSM-5 also refrains from using strict definitions, but basically states that there's abnormalities in these domains, delusions, hallucinations, disorganized thoughts, disorganized behavior, or catatonia and negative symptoms. The APA and the World Health Organization define psychosis more narrowly as just the presence of hallucinations without insight, delusions, or both. But throughout all of these, impaired reality testing remains central. We could get further into the weeds about the DSM, but that's less important than talking about the prognosis for the study. Um, our understanding of psychosis right now is largely based on what we see as primary psychiatric illnesses, substance use disorders, and causes from medical or other neurologic conditions. We do see that there are some brain abnormalities that are correlated with psychosis. And then we see that there are some epigenetic and environmental factors and genetic factors that play into this. And we can see throughout studies that some of the positive symptoms are related to excess dopamine in the mesolimbic tract, and there are other studies that show NMDA glutamate receptor and roles for GABA, glutamate, and acetylcholine in psychosis. So as far as the individual is concerned, psychosis is not good for them. It negatively impacts quality of life, relationships, physical health, all the things. You may see a PRITE question or two in the future about comorbid disorders such as heart disease, liver disease, and suicide in these patients. The epidemiology, I looked at a large number of studies about the epidemiology of psychosis and saw a wide range of estimates, but it looks like a fair number of people throughout their life will meet the diagnostic criteria for psychotic disorder at some point. And then there are suggestions that up to a quarter of people may have some psychotic symptom in their lifetime, which is a little astounding. And then we see peak ages for onset of males in the teenage to mid 20s and females to teenage to late 30s. Once again, these were widely varied through different studies that I saw. And then, as far as public health is concerned, schizophrenia has remained amongst the top 15 leading causes of disability worldwide. It kind of hangs out right at that 15 mark with COPD, asthma, and a couple of other disorders like osteoarthritis and substance use disorders. The economic burden is massive for psychosis, and for schizophrenia specifically, it was measured at 155 billion in 2013 and 343 billion in 2019. The largest driver of these costs is caregiving, premature mortality, and unemployment. Sorry, my slide seems to be frozen. Oh. Okay. I want to talk about the first longitudinal analysis relating to my study. So this was Luke Ciampi or Chiampi, I'm not sure how to pronounce that, in 1980. He studied 100 or 1,642 cases of schizophrenia, and they averaged at a 37-year follow-up, but only 289 patients survived until that final follow-up, which just shows, the high degree of mortality in these patients. Uh, their analysis showed that outcomes were largely dependent on premorbid personality factors and psychopathological factors such as the course of illness, how quickly the symptom onset occurred, things like that. And then the most common trajectory was an undulating course in which psychotic episodes grew less frequent and remission grew more frequent, which I would say is a good outcome. And recovery was 24%. That's a little bit at odds with the study that I'm going to talk about today. I'm not going to get too much into the weeds here on our current understanding of prognosis as far as numbers go, but we largely based our understanding on cross-sectional studies and who is at remission or recovery at any given time. But this can obfuscate larger trends and patterns. But we do see throughout these studies that there are lower rates of recovery and remission with schizophrenia than with other psychotic disorders, and that only maybe 1 in 7 individuals with schizophrenia ever truly experiences recovery. And then I referenced some studies that are 10 years, some that are 20, all suggesting that non-affective psychoses fared a little worse than affective psychoses as far as remission and recovery go. What is the role of psychiatrists in psychosis? We must be readily able to recognize, diagnose, and treat psychosis. It's one of our major duties. We have to be knowledgeable about the available treatment modalities, and our understanding of the prognosis allows us to educate both the patient and the family and provide appropriate levels of care. It's also critically important in informing, anticipating public health needs, public health policy, and individual needs of patients. Our current treatments, this is by no means an exhaustive list, but the first thing we typically are going to reach for here are antipsychotics. We can reach for mood stabilizers. We can do things like ECT and TMS. Sometimes we'll use antidepressants for things like negative symptoms, benzodiazepines, and cognitive remediation. One of those pride buzzwords. It's very useful in regaining and recovering cognitive function in schizophrenia. All right, here's just a little bit of information about the article I chose today. Here's the title, the authors. It was published in the American Journal of Psychiatry in May of this year and received funding for its study by the National Institute of Mental Health. Minimal conflicts of interest. The objective was to describe most common trajectories at over a 25-year follow-up following the first episode of psychosis. The methods, this was the Suffolk County Mental Health Project in New York. They used 12 different inpatient facilities from which patients were recruited from 1989 to 1995. Took around 600 patients, met criteria. They included 591 in the study. And then from that, they used a subsample of 311 for a special analysis. And I'll explain the difference there in a little bit. Data was collected at six different follow-ups at 6 months, 2 years, 4 years, 10, 20, and 25 years. The diagnoses for these patients were made by a consensus of study psychiatrists at 6, 24, 10, and 20 years. And the interviews for these patients were conducted by master's level health professionals. And the diagnoses were made based on all the available information, including the structured interview, medical records, and collateral interviews. Some of the measures that they took throughout the study include age of onset, normal demographic information, history of substance use. They documented medications that were taken throughout the course. These medications were documented by self-report, pill bottles, medication lists, medical records, things like that. If they were engaging in psychotherapy, the engagement in psychotherapy was kind of just like if you met the threshold of having received at least 20 minutes of psychotherapy in the previous 6 months. Um, and then they assess baseline symptoms using the SAPS and SANS, the schedule of assessment of positive symptoms and schedule assessment of negative symptoms. And ratings were made by interviewers that were scored into different categories such as avolition, apathy, inexpressivity, reality distortion, disorganization. So to further clarify these terms that I talked about earlier, remission and recovery, remission was to score that to basically indicate that you had remission. Your scoring had to show mild to no severity for the following symptoms over the previous 1 month. And that's hallucinations, delusions, bizarre behavior, formal thought disorder, affective flattening, alogia, and avolition, apathy, and anhedonia, asociality. And they use the SAPS or SAPS and the SANS for that. Recovery required indication of moderate or better for the following conceptual disorganization, mannerisms, posturing, grandiosity, suspiciousness, hallucinatory behavior, unusual thought content, and blunted affect and emotional withdrawal. They also had to answer questions about their social function, including indicating at least generally adequate functioning on both accomplishment and social activity. And they used the quality of life scale for that. So analysis was stratified between this baseline group of 591 individuals, and then they further stratified using this 311 subsample group. And they basically used the initial diagnosis for the baseline, and then they used the most updated diagnoses for the 311 subsample for their analysis. That's basically the only difference is that when they were analyzing, they just used more updated diagnoses for the 311. Here are some of the numbers. So the baseline group had the schizophrenia spectrum disorder 173, and then others as 418, and the 25 follow-up group had 311 people, and it was almost evenly split between the schizophrenia and other psychotic disorders. These were the patterns of recovery that were recognized, either stable recovery or remission, early recovery remission, neither, and intermittent. Some of the results that they found, the modal or most common pattern for both the baseline cohort and the 25-year subsample was intermittent remission and recovery for the other psychiatric disorders. So the most common one was that undulating pattern previously described, and then they are more likely to experience stable remission. So across all time points, they are more likely to have stable remission and stable recovery at 15 and 21%, compared to no remission and no recovery. And schizophrenia spectrum disorder, their most common trajectory was no remission and no recovery. And then they're unlikely to experience any stable remission or stable recovery at all. Some other results, this just kind of shows the difference over time. um, as far as like early follow-up compared to late follow-up amongst individuals. In the 25-year group, remission rates were 46% of these other psychiatric disorders, the OPD, and 25% of the SDD at 6 months. And you see it fall off by 25 years to 20 and 7.4, respectively. And then in the baseline cohort, 41% or 42% with OPD and 27% experience recovery in the first 6 months, and then it once again falls off by the 25-year follow-up. And then mortality reached 20% over the course of the study. And there is some way to account for these changes that we see. So there was some change in diagnoses amongst the groups, but I'll talk about that in just a second. One of some more results that they had, there was stability of remission and recovery between time points, was basically highest at the end. So those who were stable continued to be stable at from 20 to 25 years rather than kind of oscillating near the end of that time course. The predictors or the data points that showed prediction for recovery and remission include gender, diagnosis, and avolition. The predictors specific for recovery include race, treatment with mood stabilizers at discharge, and predictors of remission include socioeconomic status. All of these factors were significant with a p-value of less than 0.05. And they were basically all, well, some of these were bad things, some of these were good things. For gender, being a male is a bad thing. The schizophrenia diagnosis portended poor outcomes, avolition, poor outcomes. The only thing that was improved outcomes here was the socioeconomic status, and being on mood stabilizers at discharge improved the long-term prognosis. So we saw that 74 of the 159 individuals with schizophrenia disorders at the 25-year follow-up actually transitioned into that group from the OPD group. So we saw kind of like a further definition of these disorders that were initially either unclear or mistaken to be thought to be psychosis due to another issue. And this likely caused the differences to appear between the OPD participants in the 25-year cohort and baseline. And this suggests that those in the 25-year follow-up were more likely to be in remission or recovery at any given point in time than they actually were. Some of the conclusions of the study, patterns of psychotic disorders is often more a pattern of multiple transitions into and out of symptomatic and functional recovery. Sustained remission and recovery is very rare amongst schizophrenics, and rates of recovery were higher than rates of remission at almost every follow-up. And if you remember, the recovery includes this social functioning aspect. And so even though they might have like a higher symptom burden, they are still able to function at least partially. And then treatments were mostly limited to pharmacotherapy. I mentioned that the psychodynamic or other forms of therapy were included, but it was just if you had 20 minutes of therapy in the last 6 months, and most of them had not. And then these findings align with other major studies, including the OPUS or OPUS, which is another epidemiologic Danish study, and other meta-analysis referenced earlier that finding favorable outcomes in approximately a third of individuals, less so in schizophrenics. I wanted to identify some of the strengths of the study. The length of the study is probably one of the most important facets of this. Being 25 years long just gives us much more insight than those that occurred over 10 or 20 years. And then even the ones that did last 20 years, a lot of the assessments were made at 10 years. The breadth of the data collected, the number of data points overall, the retention rate was substantial and actually quite impressive. The defined catchment area allowed for I think less bias and more sample representation. and then the ability to generate patterns that might have otherwise been obscured in simple cross-sectional studies. I think it's easier to pick on studies than it is to support them, but I saw some limitations in the study as I was running through it. The medication data was largely self-reported, which can always lead to issues. And then it is very unclear about what medications they were receiving throughout the course, and then if those medications were optimized, if they were at appropriate doses, what antipsychotics they were receiving, that kind of thing. And then the length of study itself is both a strength and a limitation, I think, because of the length of study. I think we see that the field of psychiatry changing itself as far as practice goes and definitions and things like that. And so it's just a little tough to know how that might have affected things. And there were some other issues here, such as use of older scales. These SAPs and SAND scores have been used since the 1980s, but they don't necessarily reflect the most current research. And there might be scales that are more able to identify these symptoms and better able to uh, help us understand the illness, such as CAINS, the clinical assessment of interview for negative symptoms, the BNSS, the brief negative and symptom scale. They're a little more attractive for their reliability and their concise, accessible format, that kind of thing. Um, and sorry, just to get back. And then women were less likely to enroll in this, which may have like artificially worsened overall outcomes. So moving forward, I think it's important that we look at improving treatment modalities, as it is often the thing that's used to treat these patients. And they may never engage in therapy. They might not follow up appropriately, but we need the most effective tools at our disposal to engage with them. Engagement in long-term healthcare plan may help in the detection and response to changes of these patients who are often in and out of recovery and remission. And then I think it's important to continue to conduct these studies so that we continue to understand the most up-to-date information. Some final considerations. It's just so important to continue to expand our pharmacotherapy and engage in novel drugs and development of novel drugs. Improvements in monitoring and treatments overall, I think, are working to improve outcomes as we continue to monitor like neutrophil counts and lipid panels and things like that, that likely were not done as regularly or as effectively in the past and even over the course of this study. So I think we have a better ability to address some of these issues. And then I just wanted to present the possibility that there may be a selection bias present in the data set that makes poor prognosis or falsely depresses prognosis for those who actually never present to the hospital in the first place. Although most patients with schizophrenia do eventually make it to the hospital, some never follow up, and their course likely looks a lot worse. And earlier onset of psychosis correlates with poor outcomes, and earlier intervention correlates with better prognosis. Just wanted to give a little shout out. The FDA approved, and I might butcher this name, Cobenfy, xanomeline, and trospium chloride capsules for oral use for the treatment of schizophrenia in adults. It's the first antipsychotic approved or drug approved to treat schizophrenia that targets cholinergic receptors as opposed to dopamine receptors. So we are still continuing to make progress on the pharmacologic front. My discussion prompt, what do you all think is the most important way to improve outcomes in these patients? And are there any questions? Here are my references. Thank you for your attention. And I'll open the floor now.
Thank you, Dr. Dixon. Great job. If anyone has a question for him, feel free to put it in the actual chat, raise your hand, or I can just promote you all to panelists. Dr. Ive, did you have a question?
No.
Oh, okay.
I explained it perfectly.
I did have a question for you. You mentioned like improving treatment modalities for this population. Any specific ideas that came to mind, other than what you had already discussed?
It's tough with deinstitutionalization and everything. It's hard because what we end up relying on, I think, is mostly the tools we have available, such as pharmacotherapy um, and therapy itself. And so always just expanding access to drugs. I think expanding ACT teams is maybe one of the most beneficial things we can do too, is just making sure the patients are getting the meds they need.
And anything that you took away from this journal that will change your practice at all when interacting or treating these patients?
Yes, I think just an improved understanding of this pattern will help me just like engage in conversations with him, express the importance of staying on the medications. Because I think we've all, at this point, we've all been in EPS and we've had these experiences of people just constantly representing things like that. We see people fall off the wagon, represent. I think it's just so important to use all this data to kind of inform our discussions with the patients and their families.
Great, great. Thank you. Let's see. Any other questions for Dr. Dixon?
I will say that, based on the results from this study, it kind of lines up to, I don't know, patients who are diagnosed with psychosis and other conditions that aren't schizophrenia, especially major depressive disorder. It always doesn't really feel like true psychosis to me. It's not overt at all, and really, you don't really see it unless the patient really tells you that they're having it. So I'm wondering if some of this stable recovery and intermittent recovery and the conditions that aren't schizophrenia, because much better recovery odds with those, are because they weren't actually psychotic to begin with. That's just one of my thoughts.
Yeah, I think that's totally reasonable. And I didn't go too deep into it, but they might have been using slightly different definitions of things than we're using today. And um, but yeah, it's unclear, but I like the thought.
All right. Well, thank you again. And we will transition now to Dr. Hallion's presentation. So if you want to start sharing your screen when you're ready.
Hello, everyone. Can you see that okay?
Yes.
Okay, very good. Good afternoon, everybody. My name's Dr. Hallion. I'm a PGY2 resident here at U of L. Today, I'm going to be presenting a journal club article that would examine a head-to-head trial of psilocybin therapy plus Lexapro and psychotherapy for moderate to severe depression. I don't have any disclosures to report. So primary objectives here, just to briefly talk about psychedelics and their proposed use in psychiatry and talk about studies to date, as well as a discussion of the present randomized controlled trial that I'll be presenting today. We'll talk a little bit about the benefits of the investigation and potential areas for treatment reform when we talk about the discussion of the limitations, and not only of this study, but also of psychedelic studies in general, and just have a brief discussion on any potential suggestions for the future. So, as we all know, major depression, one of the more common psychiatric disorders, very debilitating, has a high societal burden. currently, SRIs are first line for use in major depression disorder. These drugs are generally pretty safe and effective, however, do have their limitations, namely with regards to the longer onset of action for them to produce a therapeutic effect, as well as some side effects that patients find debilitating, namely sexual dysfunction and emotional blunting. And moreover, kind of a risk of relapse and recurrence remains pretty high in people that don't sustain pharmacotherapy treatment or psychotherapy treatment after an initial successfully treated episode of major depression. So this begs the question of finding new and improved safe and effective ways that produce potentially more immediate and longer sustained results for folks that have depressive disorders. And the proposed idea by some people are these what we call psychedelics, and one of them being psilocybin. It's an alkaloid derived from the psilocybe cubensis mushroom. And the actual psychoactive or psychedelic, which means mind manifesting action, comes from its active metabolite psilocin, which is derived in the gut. It's a very potent serotonin 2A agonist, and it's thought that that receptor activity is what produces the psychedelic or mind manifesting effects related to ego dissolution in the acute phase and cognitive reappraisal and emotional catharsis, both in the acute phase and more long term. It did back in the 40s and 50s and 60s, was very popular for use both in the research setting for psychiatric disorders and addictive disorders. However, with the kind of flamboyant and recreational use by the counterculture, as well as some irresponsible use by governmental agencies around that time, these substances became Schedule 1, meaning that they have no medical use and high abuse potential. And only until recent decades have they become a little bit more popularized and as a more unconventional way of researching them for potential refractory mood disorders, end-of-life distress, and substance use disorders, though to date, comparative trials against standard treatments that we have for these conditions are lacking. Which brings us to an article that was published back in 2021, which is the initial trial for the paper that I'll be kind of discussing in more detail. So they kind of lead into each other, but this is essentially a phase 2 single site, double blind, randomized control trial examining the antidepressant responses in moderate to severe depression for psilocybin versus Lexapro. And primary outcome for this study was reduction in self-reported QIDS SR16 scale, which is a measure for depressive outcomes. And they also took a look at some secondary outcome measures as well. These were, in part, some of them were clinician-related measures of depressive outcomes, like the HAM-D scale, the Montgomery-Ashburg scale, but also other scales related to work and social functioning, meaning in life, and feelings of connectedness. And essentially what they found was for the primary outcome measure, both treatments did demonstrate improvements in depression at the trial endpoint. They didn't differ from each other. In other words, there were no between group differences in the response rates. And what they characterized as a response rate was 50% or more reduction in the QIDS scores from baseline. However, they interestingly did find some differences in the secondary outcome measures, namely related to kind of more themes related to more global mental health functioning, improvements in anhedonia, work and social functioning. Again, these are all kind of subjective effects, but nonetheless, they did find them. And it's important to note because it's relevant for the study that we'll go into more detail about is that, as you can see, there's a lot of comparisons being made. And the authors do note that, that they didn't control for all of these multiple comparisons. So as a result of that, you're more likely to make a type 1 error. So that is an important caveat. And the secondary outcome measures, the inferences made from these data are, you have to be cautious on interpreting them because of that reason. So with that previous study, that was simply just it was a 6-week study. So with this one, they wanted to kind of observe what are the sustained results of these people that get the proposed treatment of psilocybin and therapy versus the sustained responses seen in Lexapro plus therapy. And it was a 6-month follow-up. The primary outcome measure was the same. They measured it at regular monthly intervals for 6 months. And then the secondary outcome measures were a little bit more specific, and they measured these individually. And they related to 4 separate scales regarding kind of, like I mentioned before, more benefits in global mental health functioning related to work and social functioning, psychological connectedness, flourishing, and meaning of life. The below is the specific scales that they did use for those. And they didn't measure those at each monthly time point. They just measured those at the trial endpoint at 6 weeks, as well as 3 months and 6 months post-trial. So this was the overall trial design. So they recruited 1,000 people, and this was mostly through kind of like social media gathering and online forum wise. So, and we'll get into the limitations of possible selection bias relating to that. But essentially, 1,000 people were recruited after assessing them for the exclusion criteria, which included immediate or family history of psychosis, any significant medical condition, any sort of contraindication that they might have to SRIs or MRI, any history of suicide, positive pregnancy tests, they did control for previous use of Lexapro. Those people were excluded, but people that previously had used psilocybin were not excluded from the study, which I found to be, we can get into that a little bit later. And then any other potential psychiatric condition that might jeopardize the ability to form an appropriate therapeutic alliance. So things like borderline personality disorder, psychosis, that sort of thing. So ultimately, they ended up with 59 people that were randomized to either receive psilocybin or Lexapro. And everybody was told that they would be receiving psilocybin, and that was a way of managing an expectancy effect. However, the degree of how much psilocybin that they received was different. So essentially, day 0, they underwent pretrial assessment, essentially a confirmation of diagnosis from a psychiatrist, and going through, the exclusion criteria, that sort of thing. And then they also met with their 2 therapists that they would be undergoing psychotherapy with. And they did this sort of preparatory session, and we'll get into the specifics of that. But that was essentially day 0. Day 1 followed that, and that was the actual dosing session. The treatment group received 25 milligrams of psilocybin plus the standardized therapy that they used. Those sessions lasted from 6 to 8 hours. And the control group utilized a dose of psilocybin at 1 milligram, which is considered a subperceptual dose, plus the standardized therapy. Following that session, they had an integration session where they talked about the emotions that they felt and utilized some visualization techniques to elicit those emotions. And patients were instructed to either take placebo for the psilocybin group or take Lexapro for the control group, for the Lexapro group. And this was 10 milligrams of Lexapro versus placebo for 3 weeks. And then at that 3 week time point, they had another dosing session that didn't differ from the first one, followed by an integration session. And at that time, they were instructed to take 2 pills. So if you were in the psilocybin group, they took 2 placebo pills for 3 weeks. In the Lexapro group, they took 20 milligrams of Lexapro. And then they measured the 6 week endpoint scales, which we already kind of talked about in the New England Journal of Medicine paper. But in this paper that we'll talk about now, the primary outcome measures were again measured at monthly intervals for 6 months, and secondary outcome measures were measured at 3 months and 6 months. So the therapy that is used it's very commonly used in the psychedelic studies currently. It's kind of takes from the principles of ACT, so acceptance and commitment therapy, promoting psychological flexibility. So things like emotional resilience and acceptance, and going inward and kind of accepting the stresses of life. So that was the basic premise of the type of therapy that they used. And I mentioned before that there was 3 distinct therapeutic sessions. So the preparatory session, where they designed to just develop a therapeutic alliance, maybe set an intention of why they're doing this type of study or what they want to benefit from, and any sorts of memories or emotions that they may want to explore further. The dosing session included a standardized music playlist that is designed to elicit emotion from people. So, melancholic music eliciting, sadness and that sort of thing. And it's important to note that for these dosing sessions, it's really for the patient. There's not much directed therapy going on. These patients are encouraged to use eye shades and simply are told to divert their attention inward. The therapists are there to assist them, but it's really just more of a supportive nature. They're there to just make sure that the patient feels safe. And then obviously following the dosing session is followed by an integration session. They might use some visualization techniques like visualization techniques to elicit emotions that they were experiencing during the session, and other supportive treatments indicated. So this was the therapeutic kind of framework that was standardized between the 2 groups. These are the demographic characteristics. So I think it's important to kind of make note of what kind of patients are in this trial. And this is a common theme among trials like this, and we'll get into why that might be limiting for drawing inferences. But mostly affluent folks have a high level of education. And down here, you can see the baseline QID scores. So, not necessarily severe depression, but the trial was aimed at just assessing moderate to severe depression. And I thought, interestingly, most of these people did previously receive psychotherapy, and they also assessed whether or not there was previous use of psilocybin, and the majority of people hadn't previously used. So this is the primary outcome arm. So at each of the follow-up points, they didn't observe any between group differences between the psilocybin and Lexapro group. However, within group analysis showed that there was significant difference between their baseline scores. So each group did have an antidepressant effect that was sustained for 6 months. And we'll talk about the secondary outcome measures first, because it relates to the primary outcome. But kind of in line with what was seen in the initial New England Journal papers, that there was demonstrated significant differences in these other secondary outcome measure scales between the Lexapro and psilocybin groups, namely that the psilocybin group seemed to have a little bit more of a superior efficacy with regard to improvements in work and social functioning, meaning in life, as well as connectedness. But in this follow-up study, there wasn't any observed difference in baseline flourishing scales. And as you can imagine, I mean, we can't point out each of the dots, but the authors did make note of that there was missing data from all of these follow-up time points. They did correct for that using a fancy statistical analysis called an imputation analysis, and they wanted to be more conservative for that. So what they did was they utilized that for the worst possible outcome for psilocybin, and they allowed the best possible outcome for Lexapro in this analysis as well. And even despite that, none of the data that didn't control for the missing data, none of it it didn't matter in that imputation analysis. The primary outcomes were still similarly efficacious, and the secondary outcome measures, the differences between the two groups held up after that analysis. And this is just the chart of follow-up treatments that they had. So after the 6-week time point of the trial end, participants were essentially instructed that they can pursue whatever treatment that they want after that. So this data wasn't controlled for. However, they did make note of what types of treatments the participants did engage in. So this is noted in that chart right here. Both groups did vary significantly in what kinds of treatments or the degree of treatments that they received. So, I think this is an important paper to talk about because it served as one of the first studies assessing antidepressant outcomes in a proposed treatment for depression, for moderate to severe depression, versus a clinically established standard of care treatment. And this observational follow-up that we talked about is one of the ones that it's beneficial to see because it's assessing whether or not there were sustained clinical responses between the two. What they found was that there were significant differences within the groups. However, there was no between condition differences across most of the time points. And in line with the initial 2021 paper, there were between group condition differences in these other offshoot secondary measures. Additionally, there was a similar side effect profile between the groups, and no significant adverse effects were noted between either group. So I just want to talk briefly about what might be going on. Obviously, both drugs work very differently. So this is a proposed theoretical basis for why these things might be working the way they do, because obviously they work very differently. So it's thought that perhaps the SRIs are working via a more serotonin 1A agonistic route, where patients are allowed to better passively cope with things. It allows them to tolerate stress a little bit better, reduces kind of day-to-day stress, and particularly by working through 1A receptors, which are more predominantly found in the limbic system, versus the antidepressant modulation by psychedelics, which are obviously done by the 2A agonism, or at least that's what the proposed theory is of why they might be doing what they're doing. And the 2A receptors are found predominantly in the cortex. And so it's thought that perhaps by agonizing this receptor the way it does, perhaps the psychedelic effect is reducing, or I guess improving psychological flexibility with augmentation of with psychotherapy. So where we can become a little bit more adaptable, a little bit more sensitive to change, and be in a state of reappraising more rigid beliefs that we once held. And it's thought that through contrary mechanisms, both can lead to decreased depressive symptoms as well as increased well-being. So the study is obviously not without limitations, and these are kind of correlate with limitations of psychedelic studies in general. So first of all, this study, as well as others in the past, are pretty small. It's hard to do these types of trials given the extensive therapy that's used. So the study isn't necessarily adequately powered to detect potentially small but meaningful differences between the groups. And as a result of the sample size being pretty small, it also increases our chance of making type 2 errors. So I did mention before the issue with the missing data, and that obviously brings into light any sort of definitive inferences that we can draw, and it also leads into potential confounding factors of that might be influencing both the primary outcomes and the secondary outcomes. So, but also the attrition bias that we see in the study. So the treatment seeking behavior, they were assessed, but obviously the authors didn't control for any of it. So again, it's difficult to draw any inferences on whether or not the sustained effects seen in both treatment groups were due to the actual treatment itself versus the treatments that they sought out after the trial endpoint. So as a result of that, we really have to interpret these data with caution because of that. So as you can imagine, and this is a problem with all of these types of studies, is the ineffective blinding and the importance of expectancy. So, the acute subjective effects of psychedelics is quite different than SRIs. Patients and therapists know who is intoxicated on a psychedelic. So that can obviously influence results down the line. And I think it's also important to note that expectancy really, I think, plays an important part in these trials and might confound the depressive effect or the antidepressive effect that we see in these drugs. Namely, these are patients that are self-reporting to these studies. They want to be a part of these trials. They may have a kind of more negative view on conventional treatments, and they feel that they generally have a more positive light on the proposed benefit of these treatments, and as a result, their positive expectancy might be enhancing a placebo response that they have. So obviously, that's a limitation on any inferences that you can draw as well. So again, that kind of leads into the selection bias. These studies recruit a particular type of person. As we saw in the demographic data, there is not much heterogeneity in the samples. These are largely white, affluent folks with more moderate depression. So going forward, it really needs to be better assessment of how we can get a more heterogeneous sample size, as well as people that are perhaps more psychedelic naive, not necessarily from a lack of use in the past, but maybe they just aren't familiar with them at all. So going forward, that's important. So also the trial design, while innovative in that it compared head to head with a standard treatment, The initial trial did propose to have a third placebo group, so a group in which they received 1 milligram of psilocybin at the dosing session, but then were instructed to take placebo pills afterwards. But since this was a phase 2 study, there were limited resources on the ability to do that. The authors note that it would have made analysis pretty complicated. So they didn't end up doing that, obviously. But also potentially the use of an active placebo group could be worthwhile in the future. And we can get into that a little bit more in a little bit. But also a limitation is a lot of confounding variables. So what is the actual true therapeutic effect of the therapy itself? So being in this room, being supported, listening to music, what is all that doing, and how does the actual proposed pharmacology of psilocybin and Lexapro, how is that influencing the treatment outcomes? So a lot of confounding data also related to that. Um, you know, with the treatment seeking behavior, I think it's important to note that it's not common to see very like long-term sustained responses with Lexapro after discontinuation. So, I think perhaps some of the effect that we're seeing in both of these groups could certainly be attributed to the intensity of psychotherapy that was given. So I think if you map out the actual hours that were given to people, it ended up being close to about 20 hours of therapy, which is a fairly standard dose of therapy over the course of about 6 weeks or 6 months, but it was kind of condensed to this 6 week time period. So perhaps it's the intensity of therapy or other spurious factors like post-treatment intervention that was producing these sustained results in either of the groups. So again, any sort of inferences that are trying to be drawn from the initial study kind of need to be taken with caution because of that. Another limitation is the side effects, though they were measured at the end of the 6 week trial. They weren't examined in follow-up data. So any assessment and comparison of long-term side effect profile between the groups, we don't know the answer to that right now. And then furthermore, one of the limitations that I feel like is important to note is the reliance on self-reporting measures. I think in real world, like ideally, it would be nice to be able to have hard outcomes to measure, like hospitalization, days missed of work because of this particular illness, or money spent going to emergency room or doctor's appointments because of that. It's just you get into a lot of problems when you're talking about retrospective self-report. People that might have their bias about psilocybin itself, that certainly can influence how they're self-reporting on these kind of subjective scales. So in conclusion, this was one of the first studies examining both psilocybin and intensive psychotherapy with a standard of care treatment, which is SRI plus psychotherapy. And the study did show similar antidepressant responses, and perhaps the psilocybin and therapy group provides additional benefits beyond symptom reduction in major depression disorder. Perhaps these differences may be more clinically meaningful to patients' quality of life. However, the caveat is that the significant limitations in the study that we just talked about really, you have to take it with a grain of salt. You can't really make any definitive conclusions based on these limitations. So I think it's overall a fair study. Again, it's a fair phase 2 trial, so it's determining potential efficacy and safety. So I think with the limitations and the data that's been shown, it perhaps informs trials in the future and potentially phase 3 trials in the future of how to go about doing this better, and to potentially control for expectancy effects a little bit better, and perhaps use or perhaps become less reliant on self-reporting measures and maybe use more clinically or clinician rated scales and clinical assessments and perhaps hard outcomes in the future to maybe make more clinically meaningful inferences about all these things. These are my references, and I'll take any questions from you guys. Thank you for your attention.
Thank you so much, Dr. Hallion. I will again promote some of y'all to panelists to ask a question, or you can just feel free to put it in the chat or Q&A directly. I had a couple questions, Jake, actually.
Yeah.
When was this published again, or when did they conduct the research? What year?
So the initial study and the observational follow-up, this was all done in 2021. And part of the reason, again, why they propose why there may have been some missing data is they had some complications with the pandemic as well. But yeah, so the initial trial was done in 2021. This paper in the Lancet was published last month.
Okay, okay. It's interesting that they had so much of the expectancy issues and selection bias. Like it just makes me wonder what the motivations were of the research group themselves. Like even though it was a phase 2 trial, it's just interesting.
Yeah. Yeah, I think a lot of these researchers have, yeah, they bring their own expectancy in as well. These are folks that have largely dedicated their lives to studying this particular thing. They have a favorable view of it. Um, it is interesting. It's unconventional. So, but you're right. I think both researchers and participants in these trials do have their own expectancy. But to be fair, I do think that they did a fair job of criticizing their own work and laying out their own limitations and trying their best to um, kind of acknowledge that and utilize statistical fancy statistical analysis to draw more accurate conclusions. But even despite that, I think with everything said, it's hard to draw any firm conclusions.
Yeah, exactly. Any other questions for Dr. Hallion? Oh, we do have a question. Hold on, let me. Okay, I'm promoting you to a panelist. So just give it a second here.
Hey, Dr. Hallion, thank you so much for the very well laid out presentation on this very interesting topic. I have a question that's not necessarily related to this particular journal, but more in general, what your thoughts are in terms of how psilocybin works. Um, you know, compared to Lexapro, which is a non-specific serotonin promoter that should theoretically work on all of the receptors, including the, serotonin 1A receptor and the serotonin 2A receptors, and so on and so forth. What makes psilocybin more likely to work on the cortex rather than the limbic system, for example, or promote these kind of hallucinogenic effects? And do you think there's another mechanism of action that might be at play here?
Sure. Yeah. And I think any question or any answers that are given to that question. It's really all theoretical at this point. Nothing's definitive, but I think the researchers would say that it has to do with this specific 2A agonism, that specialized cortical response that you're getting. So, and regards to the hallucinatory effects and the synesthesias that people might experience, there's some proposal that that might be due to disruptions in thalamic gating, and neuroimaging data and other studies have shown that people that are acutely intoxicated on these drugs, their brains are working a little bit differently. They're working in a less rigid and hierarchical fashion. So, in other words, areas of the brain that typically aren't communicating with each other, they do begin to communicate with each other in acute intoxication. So, you know, whether or not that's the reason for the proposed sustained treatment outcomes, I'm not entirely sure. I think for the acute effect, it might be that, it's opening your mind up to being a little bit emotionally reasonable, a little bit observing these perhaps more rigid belief systems that people have in a more compassionate way, maybe allows them to reframe them more easily. And obviously, when you're augmenting it with psychotherapy, it's hard to determine whether or not it's the actual pharmacology of it versus some sort of synergism. And I think my gut would be that there's probably some sort of synergism that's working with the therapy itself. And this goes back to the idea of set and setting that was popularized by Timothy Leary back in the 60s. And I think that that's important to understand. And maybe it's not all just this agonism of 5-HT2A that's producing the response, but maybe it's just this very loving environment and whatnot that's helping guide that process along.
So essentially, you think that it sort of opens your mind and your circuits to be more receptive, and so you get more synergism from the setting and like the therapy, the music, uh, and everything that you go through, the intensive kind of um, a course of treatment that you get, that is only facilitated by that process of just opening your mind up by the psilocybin rather than the psilocybin's action itself, correct?
That's what I would venture to say. Perhaps in the future, they might. I know that there's some looking at ways of getting around some of the limitations of these studies. Some people have proposed administering these drugs while people are under anesthesia to see if there's a similar antidepressant response or similar response in these secondary outcome measures. But I would venture to say that that's probably not the case, and that the augmentation with therapy is almost a prerequisite.
Thank you so much.
There's another question in the Q&A. Have you seen any research that compares lithium with psilocybin?
Nope, can't say I have, but I would be interested to see what that shows.
All right, good deal. Well, excellent job, both Drs. Dixon and Hallion. Thank you so much. Hope everyone has a good rest of your day. Thank you.
Thank you, guys.